I'd like to introduce our first speaker, who is going to give us his perspective from the governor's chair. And it's Devid Levine, who's the president of DL Consulting Health Systems Strategic Management. Now, Devid has had various views of the health landscape, both as the former president and executive director of the Montreal Regional Health and Social Services Agency. He was also in government as a junior minister of health in 2002, and Quebec's delegate general in New York City in 1997. That's one of the better gigs in the diplomatic corps. But he was also past president and CEO of the Ottawa Hospital, the Notre Dame Hospital Montreal, the Verdun General Hospital, and the Centre Local de Services Communicateurs. And that's why I don't speak French, because it does nothing to help national unity. Without further ado, I'd like you to join me in welcoming Devid Levine to the podium.
Thank you so much, Connie, for the introduction. Thank you for the organizers, for Dick for having invited me. If your instructions, Dick, were a little clearer, I'd have a clear presentation. It says what success looks like. Dick, in a phone call, said to me, David, I want you to talk about the value proposition. Had to look it up in the dictionary to figure out what it meant, the value proposition, got a good understanding of it, and that's what I'm going to try to deliver today. What is the value proposition for government? That means for the Minister of Health. And what is it for a regional authority? I've just left after 10 years the Montreal Regional Health Authority. It's a 1.9 million population, $6.3 billion budget. There are 43 public institutions, 17 emergency rooms on the island. I needed data to run that. And I'm going to talk about the kind of data I need and what does success look like and what's already available. So the first thing I want to do is, what is the role that the minister or government or the regional authority plays? Well, there's a role in planning programs. We need to be able to plan the programs and the policy that go along with those programs. We need to be able to allocate funds. We need to be able to allocate physicians. So the way you allocate physicians throughout the province. We need to be able to measure performance. We need to be able to measure quality. We need to be able to plan services according to the needs of the population. So you have to be able to evaluate the needs of the population according to their socioeconomic needs, according to their age, et cetera, et cetera. And we need to be able to optimize care. We're in a situation where the financial constraints are very present. So what are the issues? What are the issues for a minister? What are the issues for a regional authority? And they are political. They're not necessarily healthcare. Now, there's a very strong link between the political and the healthcare, and I'm going to give you the political ones. Political issue, accessibility. Access to walk-in clinics, access to a GP, access to a specialist. That's a political issue which generates dissatisfaction in the population. Wait times, diagnostic testing, intervention in surgery. Wait time is a political issue. We certainly know about that. Emergency room services, waits in the emergency room. It's a political issue. Care to the elderly from the point of view of accessibility but quality. Headline in the newspaper, daughter indicates that her mother eats cold toast because the toast has to come up from downstairs to the floor, and when my mother eats it, there's no odor, no smell of toast on the floor. It's made headlines in the newspaper. And I had the ministry calling me up with the quality of care in this organization and the food that was available, okay? So these are the type of political issues. So chronic care management, which we think is a big issue, is a solution, not an issue, okay? Quality of care in terms of nosocomial infections that we talked about. And we publish the rates of those infections, and when those rates are high, media provides a headline, that becomes an issue. Sustainable funding in the system. Government just implemented a tax of $200 per person throughout the province of Quebec per taxpayer to be able to fund a part of the system, and indicated that this was for development of new services in the system. A very tight system, but the issue of funding is very important. So when we look at it from a government point of view, the regional authority point of view, there are two types of data and the importance of data. First type of data is the administrative and activity data. The second type of data is the medical record data. So I look at this from the perspective of those two types of data. And when I thought about data, and the people around the table, everybody in Infoway today and our key players in healthcare, at least to me, have all come from CIHI. When I looked 10 years ago, the CIHI group of Michael Dexter, Graham, Dick, Glenda, Jennifer, Brian, Tom Clausen, everybody was involved in data. And then somebody figured out we needed to find a way to collect that data. And so they all moved over to another organization to find a way to collect the data, left behind an extraordinarily good CIHI group, but really saw the focus of how to now collect the data that we needed. So if I take a look at the administrative and activity data, the one we have for the longest period of time is payment. Okay, so we've been able to, it's a huge rich data bank of payment, Medeco, what we collect from our hospitals. There is a lot of it, and that's where our informatics systems developed. They grew up on the payment system. Performance in terms of resource allocation, but certainly now pay for performance. Quebec has just implemented a new pay for performance team of experts that will try to design a pay for performance methodology to allow for funding of our institutions. You can't do pay for performance without the data being collected. The use of services vis-a-vis the needs of the population. Where does the population go for their services? What services do they need? When they need new, we moved from 29,000 to 35,000 births per year on the island of Montreal. I had capacity for 29,000 births. I needed to find 6,000 more spaces for births on the island. Where were they? I needed to collect the data to find out who could do it, where we needed to do it, where was the growth potential. It was the immigrant population coming into the island of Montreal in the center of the city where I had least access. I had greatest access on the peripheries. So how do we use that data to provide the services that we needed? The physician allocation is a complex issue, and especially between different regions, because in Quebec we really give the numbers very specifically, and it is the major complaint of our organizations. And then there are the quality measures that we need to collect. So some of the successes, what's been done, we have an excellent new bed management software in our organizations that's being put into place. Home care software to manage the routes of our nurses and home aides so that they become more efficient. There's maintenance software, stock management software. There's chronic care management software, which is an excellent teaching tool for the individual for self-management. Huge involvement of mobile technology is becoming more and more important. And if any of you have followed the HealthWise handbook, it has now become electronic and interactive, and you can use that as a way of measuring your own healthcare needs. So there is huge advances and successes in the various technologies and software that is coming online in this area of what I call admin and activity data. Now we take a look at the integrated electronic medical record and the data from that, and how will that help government, and how will that help a regional authority? As a regional authority, I do not do the offering of services. I oversee the 43 public health organizations in health and social services. Now, we haven't talked a lot about youth protection, we haven't talked a lot about mental health, we haven't talked a lot about rehab, we haven't talked a lot about intellectual deficiencies, but all of those areas require data. They require registries, and we can't only look at the medical side in the hospital. And that's a component that has to be looked at. So whatever systems are put in place, They have to have the modules, the capacity to add the data that the clinicians come up with, whether it's in mental health, to do the evaluation of the patient and have a protocol for the appropriate evaluation. That has to be able to fit in to the electronic medical record and interact with the other kind of data that's in that record. Okay, and we can't ignore that, that component. So when we take a look at the electronic medical record, its advantages. Well, we're going to have managed care. And the primary care role of coordination, mentioned this morning, the importance of coordination. The medical record will allow for much better managed care. As you hand off from one professional to another, they're going to be able to follow the protocol, and we're going to be able to introduce the protocol into the patient record. Much less duplication of tests. We're not going to be doing the same CT scan twice as we go to one institution to another. So there's going to be very distinct savings. From a regional perspective, when I look at the number of tests we do on the island of Montreal, the ability to reduce those tests, look at the pertinence of the test, so you need the data, and you need to be able to see how often do you test the same patient with the same type of test. A great deal of saving of time for the physicians. And in terms of the accessibility issue for a general practitioner, in a GP group practice in Verdun, where a software was implemented from KenLogic, one of the groups of many that are providing this type of service. The physician, when I went to visit, clearly indicated that in an 8-hour day, she saves 45 to 55 minutes of her time simply because she has an electronic medical record. Paperless environment. Her prescription comes out of the printer, given to the individual clear. Not yet directly to the physician's office, to the pharmacy, excuse me. That will come very soon with our DSQ in Quebec, but at least you can read the prescription. So that's very helpful. She saves 45 to 55 minutes a day. The increase in accessibility just from that alone is of huge added value to what we're trying to do in the regional authority. Much safer medicine. We spoke about this morning, Dr. Bates talked about the errors in medication. We had Connie give her example of the error of medication. The cost of that, and we're tracking the cost of that on the island of Montreal is very significant. We're going to look at better continuity of care and the importance of continuity of care. As we've regrouped and merged institutions, certain institutions on certain sites are doing one thing. They're regrouping the activity in another place. We're reorganizing the way care is given. So there's a lot of handoffs. There's more handoff of the patient from one place to another place. As you get more handoffs, it gets more confused if you haven't got the data following the patient. And so as we're regrouping cardiology, we're regrouping nephrology, we're regrouping neurosurgery, we're regrouping the types of cancer and where certain cancer sites are being dealt with, and as you pass the patient from one to another, you need the data to follow the patient. So the transfer is very important. There is better uniformity of care, so common protocols. The common protocol and the difficulty of getting physicians to use a common protocol. The one example, the different types of hip and knee replacements that you would find on the shelf in a hospital, and the difficulty of just standardizing it to one or two types as opposed to the multitude of types. That's just one example. Think about the actual clinical protocol for the patient and the necessity to standardize that with what we call les données probantes. There's an important role in teaching. Now, we haven't talked about teaching in the academics of having a unified medical record, but for the students coming out and being able to use and learn in that environment is going to change in a very significant way how they are going to practice later on and what they're going to be used to doing. Okay? So we can't forget that academic component of the electronic medical record. We haven't talked about the research. We haven't talked about how the electronic medical record and the data we collect is going to influence research in an incredible way. The way the virtual teams have now done across Canada, this is going to be a sea change in terms of the kind of research that we're going to be able to do, certainly large-scale research. Emergency room care is going to become hugely safer. than what it is today. I sit on the board of Urgence Santé, which is our ambulance services, and I rode around in those ambulances, and when we pick someone up and they're lying on the floor in their apartment, if we had access to information on that patient as we went into the home, I'm telling you, the level and quality of care to that patient would significantly change. So from a regional point of view, that's where I am, those are the important issues. From a government point of view, you have to look at the political component, but you can see how the collection of the data is going to be able to allow ministers to respond, indicate what's being done, use the data appropriately, and make the appropriate policy decisions. Success. One example. We have, in one of the 12 networks on the island of Montreal, set up a home care telehealth proposition for chronic care management of patients leaving the hospital. So they spend a 4-month period in the home, and they collect all their health data, and it is transmitted either mobilely or by the phone to a nurse who has a central computer that she follows the data and interacts with the patient. Results. This program is going on for about 1.5 years now in one area with 100 stations that move every 4 months in the territory of a 200,000 population. The nurse used to visit 12 times a month for 4 months, now visits 2 times a month for the 4 months. The nurse was able to manage 20 patients. The nurse now manages 80 patients. The cost saving alone, because the regional agency loaned the money to the organization paid back within 1 year instead of 2 years, a high payback. So the business model we're looking at has got to be done somehow on a payback venture. This particular case was very good. We're now extending it to the whole island of Montreal, and that instead of 100 stations, we'll go to 1,000 stations throughout the whole island. That's an example of what I call what is success in the area of using informatics, because that is one of the bases of this. One of our agencies, one of our networks, simply digitized all their paper records, got rid of all their paper records, created a medical record simply by the photo of every piece of data. It's not the most efficient way to do it, okay? It's self-financed over a 5-year period because of removing all the staff from archives that used to have to do all that work. And now what we're looking at as the ability to write into that file in what we call an O-word software that has been developed on the island of Montreal. And so in a backdoor way, an organization has come up with an electronic medical record that isn't as interactive as we'd like it to be, but quite honestly, that was what I consider success. The organization is happy, the nurses really love it. The other success I want to talk about is the ability for regional authorities to do region-wide IS systems. So throughout the island of Montreal, we introduced a single medical record implemented throughout the island of Montreal. I've spoken about it many times, the Oasis project, that has allowed the whole island to come onto the same platform, and as each organization is being hooked in, and it's not only the platform of hospitals, it is the platform of mental health, it will be the platform of youth protection, it will be the platform of intellectual handicapped patients and rehab patients. So the project was designed to be able to include all the components of the system. Just want to end up by saying that there is a really good fit for what government and regional authorities need to the 5 elements that the planning strategy of Infoway came up with. It's in, I believe, in the package. It's care closer to home. It's enhance the patient experience, very political, enhance the patient experience, that's what the politicians need. Support the new models of care, and those new models have to provide financial interest. Improve patient safety, which once again will improve the financial interest, and enable a high-performing system. So there's an excellent fit to what is the value proposition for government and the regional authority and what Infoway is trying to do. Thank you very much for your attention.
David, thank you very much for sharing your insights, both the public policy and political processes. I'm sure there are going to be questions of you when we wrap up this panel. I would next like to invite to the podium Dr. Michael Golbey, who is, unlike my father, more than a general practitioner. He practices in Kelowna. He's actually been on the board of Infoway for 6 years. I had the privilege of serving on the board with him. He is the chair of Canada Health Infoway's Clinical Council, chair of the board of the Canadian Medical Association, and he was also the past president of the BC Medical Association. But he is here primarily to give you his perspective from a clinician's view.
Thank you very much. Thank you for that introduction, and thank you to Infoway for the opportunity of sharing my experiences with you from the viewpoint of a clinician. As Connie mentioned, I'm a family doctor in Kelowna, and I've been there since 1983, so for 29 years. When I started my practice, it seemed obvious to me that there had to be a role for IT in helping to manage the information that would inevitably be flowing through my office. Yet it took me until 2010 to finally implement an EMR. And I don't plan to go into the multitude of reasons why I think it took so long. Maybe I'm just a slow learner, I don't know. But actually it confirms that in this particular area, I'm not an early adopter. And that's important because the early adopters will make anything work. They're committed and they're going to put whatever effort they need into it to make it work. I'm not an early adopter in this. And my comments, I think, should apply to the bulk of physicians who are just now taking on the challenge of implementing EMRs. I do believe that a number of events have come together in the last few years that have and will continue to accelerate the adoption of EMRs by clinicians. In general, physicians will adopt technology when it can be shown that there is a significant benefit to them and to their patients. We were early users of personal digital devices such as Palm Pilots when drug databases became available on that platform. We were also very early users of pagers and beepers long before drug dealers and call girls used them because it was a way of making our life simpler. The practice of medicine has become increasingly complex over the years. In particular, in family practice, the advances in chronic disease management have meant that monitoring these patients involve more and more lab work and often increasingly complex pharmaceutical regimes required by patients with multiple medical problems. And as hospitals continue to deal with only the very sickest of patients as inpatients, our patients in the community require and receive help from various disciplines, be they long-term care nurses, physiotherapists, pharmacists, dietitians, and the list goes on and on. Trying to coordinate all of these healthcare professionals with the patient, their families, and the community agencies has become increasingly difficult. In the paper world, the flow of lab results, x-ray reports, hospital discharge summaries, faxes from nursing homes, pharmacies, community nurses, and others have become an absolute torrent. And both I and my office staff were spending more time dealing with paper than we were with our patients. Something had to change. And it is my contention that introducing an electronic medical record to my office has started that change and will continue to very significantly improve the medical care I can provide to my patients, as well as the enjoyment I get from the practice of medicine. So why 2010 and not many years earlier? There certainly were many early adopters of electronic medical records, but it really has taken until now for this to become mainstream in Canada. I really believe that only recently has the technology become reliable enough for it to be used by a large number of physicians without having to have the support of an IT department, which is obviously impractical and way too expensive for a small office. Also, the flow of information into a physician's EMR needs to be relatively seamless. Simply scanning reams of paper into an electronic chart really does nothing to help organize that information. And without doubt, to my mind, funding needed to be in place to encourage physicians to invest in these systems. So let me describe my journey into this brave new world, why I believe we have succeeded, and where we will go from here. In 2006, the British Columbia Medical Association negotiated a new contract with our provincial government that for the first time included funding for the implementation of EMRs. This funding would help cover the cost on a shared basis for the purchase of hardware, software, change management, and implementation. This type of funding had started in other provinces and continues to be implemented by most provinces and territories across the country. There are a number of approved vendors whose software could be used, and because of the large numbers of interested physicians, funds were allocated basically by lottery. My office received funding in 2009, and it took approximately 1 year from the time we were approved until the day we turned on our system. Coincidentally, and most fortuitously, at the same time as we prepared to switch to an EMR, Interior Health in BC was able to start streaming huge amounts of data electronically directly to us. This included laboratory and diagnostic imaging, whether that came from public or private facilities, and most hospital-generated information, admission, discharge summaries, consults, etc. So from day one, the number of pieces of paper that appeared on my desk shrank from well over 100, probably several hundred, to 10 or at most 20. So what a huge change that made from the day we switched on our EMR. Prescriptions were printed instead of being written, which cut the number of phone calls from pharmacies. Drug interaction checking was done at the time of prescribing, which further cut down the number of phone calls. And as we gained more experience with our system, most of our requisitions for lab, X-ray, other diagnostic testing, etc., were generated electronically, thus enabling us to physically remove more and more paper from our workspace. We actually started to look as though we were working in a 21st century environment. Previously, my patient encounters had been handwritten by me in the chart. Frequently, I had difficulty reading them when the patient came for their next visit. Now they were legible to me and to others who might have legitimate access to that information. My workflow changed dramatically. Instead of receiving a sheaf of lab results in the late afternoon, which I then had to stay late to read, evaluate, and request paper charts on some of these patients, results now flow to me through the day. And I can review them in between patients, call up the chart electronically if I need to, and request my MOA to call the patient in or do whatever else needs to be done for that patient. Excuse me. My MOA no longer has to retrieve paper charts and file results. This has freed up her time to use her skills running a much more efficient office. An interesting side effect of this better and speedier information flow is that many of my patients have discovered that if they go to the main lab in Kelowna instead of one of the branch collection stations, there will often be a result available before they even arrive home from the lab. So this is very important for those who, for example, rely on frequent INRs to regulate their blood thinners and the dose of medication that they need to take. After 18 months of using my EMR, most of the information I need on each of my patients is now electronic. So that, for example, during an appointment for medication renewal, I can spend most of that appointment reviewing my patients' concerns, making sure their labs are up to date. Actually, printing the prescription is just the push of a button instead of a laborious, handwritten procedure. As I was preparing for this talk over the past couple of weeks, during each patient encounter, I thought about how different that encounter was using my EMR compared to my old paper-based system. And when I asked Richard what I should talk about, he said, talk about your experience, talk about patients, people love stories. So if I may, let me give you one example. Mr. A, who came to see me last week, is an 80-year-old retired aerospace engineer. He's very active, he loves to travel, and he's an excellent bridge player. However, he has a number of medical problems and recently had to have vascular surgery. The surgery ended up being more complicated than expected and was further complicated by a post-op infection. His appointment had been booked for a medication renewal and consequently was a standard 10-minute appointment. He's on a number of medications, and prior to having my EMR, It would have taken most of that appointment to review his medications, laboriously write them out by hand, then transcribe exactly that same information to my paper chart, and no doubt deal with the phone call later on that afternoon from the pharmacist when she couldn't read what I had written. Instead, the medication review and prescription printing took less than a minute, allowing the rest of the appointment to go over his surgery, his consults, his discharge summaries from the hospital, to discuss any follow-up needed, concerns that he has, review the lab test done in the hospital, and still have time to listen as he told me about the great bridge hand he had had the day before. What about direct benefits for my patients? As I mentioned, I receive all sorts of required data on them much more quickly, and this without doubt contributes to improving their health status. I can easily determine when particular tests are due and make sure they are ordered. My EMR will also report to me when a patient has not gone for a test that has been requested. We can now track this and follow up when it is clinically necessary, much to the surprise of some of my patients, I might add, when they get that phone call. And that had been impossible. That was impossible with a paper-based system. I am able to show those patients who are interested how their various clinical parameters are doing. For example, print out their cholesterol values over the past year or so, or their weight, or their blood pressure. This absolutely allows them to become more of a partner with me in their medical care. We are fortunate in our practice to have other healthcare professionals help us. We have two nurse practitioners who go out into the community to nursing homes and patient homes for those who are unable to get into the office. They take their laptop computers with them, and they can instantly access all of that patient's information, medical profiles, recent labs, consults, etc. They then input their encounter with that patient and message me that they have seen the patient. This allows me to review the encounter and add my comments. This is obviously hugely beneficial to my patients and really is an example of true shared care. On occasion, we receive drug alerts about drugs that are in common use as new information becomes available. A recent example was concerning the combined use of a statin and a calcium channel blocker, but only for doses of that statin greater than 20 milligrams. So I was able to find any of my patients on that combination within a few minutes. Can you imagine trying to find that with a paper-based record? Not just one drug that was a problem, combination of two drugs, and one particular strength of one of those drugs. It would have been totally impossible under the paper-based system. Did it save that patient's life? Probably not, but that sort of information spread over the entire Canadian population most certainly will. Immunizations. Records of immunizations across Canada have always been very haphazard. There are so many locations where immunizations can be given, and there is not yet any coordination at all. However, this year, for the first time, all the flu shots that I gave in my clinic were recorded electronically. Had there been a major flu outbreak, I would have easily been able to find which patients had not been immunized by me and then contact them to take appropriate action. When I'm on call, I have access to medical information on my colleagues as well as my own patients. If I have contact with one of my colleagues' patients during my on-call time, I will annotate that in their electronic chart and leave an electronic message for their physician so they can follow up. My call group is 4 physicians, but only 3 of us have an EMR, and I have no doubt whatsoever that the patients of those 3 physicians get much better after-hours care than do those of the 4th physician. So where's all this going? We still use a lot of paper unnecessarily, in my opinion. My prescriptions are generated electronically, then they're printed out and given to the patient to be taken to the pharmacy of their choice, to be inputted manually by the pharmacist into their system. I really hope it won't be too long before my electronically generated prescription will go automatically to some central pharmacy computer to be accessed by the pharmacist of the patient's choice, thus eliminating the possibility of transcription errors, lost prescriptions, etc. A useful outcome from this will also alert me when a prescription hasn't been filled and allow me to investigate the reason, and that happens surprisingly frequently. Similarly, for requisitions of all types, It makes no sense to me to electronically generate lab requests, then print them out and give them to my patient with the same possibilities of loss, error, etc. Consult requests to specialists are also currently printed by my system and then faxed. This requires follow-up to make sure the request has been received and an appointment given. How much simpler this will all be, including allowing the specialist access to my electronic chart if he or she requires more information than I have provided. Point of care clinical information will be very valuable to me. The Canadian Medical Association is investing significantly in knowledge for practice. Once this is just a click away in my EMR, my ability to provide the most up-to-date care will be dramatically enhanced, for example, using products such as Dynamed or clinical practice guidelines. This switch from paper to electronic medical information was brought home dramatically to me just a couple of weeks ago. Most of you will probably recognize the CPS, that's that big blue book of drugs that every physician consults on a regular basis. Each spring, the new edition appears, and the old tattered dog-eared one is donated to some worthy cause. I was astonished this year when I dug out my old one to find that I hadn't opened it all year. My drug information searching has switched completely from paper to electronic without me really being aware of that. What else were my patients like? Well, I believe that many would enjoy being able to make their own appointments electronically, and I really don't see why this should not be possible. I booked this entire trip, my flights, my hotel accommodation, without actually talking to anybody. I'm sure it's possible to set up rules that would allow patients to book appropriate appointments online if they so choose. Also, access to their own results. Patient self-management of chronic disease is becoming increasingly important, and we really do have the technology now to enable our patients to access their own results when this is appropriate. It is an exciting new world that without doubt has renewed my interest in my clinical practice and is improving the quality and the timeliness of the care that I can give to my patients. Thank you very much.
Thank you very much, Michael. It was a very insightful, clear, and passionate presentation. Lastly, in our panel, I'd like to call to the podium a man who needs no introduction, and he was introduced earlier. It's Allan Gregg, who is not just one of our leading pollsters, but one of our leading opinion leaders and a very thoughtful spokesperson on issues relevant to all of us in the room. Allan.
Thank you. So, what do Canadians want? Well, at bottom, two very, very simple things, pretty much as they've always wanted. They want more services, and they want lower taxes. So that's pretty simple. I make the point only half facetiously, because the sad truth is, as it stands now, and left to their own devices, individual Canadians are not going to be much help in bringing about healthcare reform. In fact, rather than providing guidance, Canadian public opinion presents something of a problem for healthcare reformers. The reason for this is very simple and very fundamental, and that is that there's a widespread consensus among Canadians around problems facing the healthcare system, but there is no similar consensus around solutions. Canadians believe that the system is in decline, and unless changes are made, it will continue to deteriorate. Basically, that the quo has no status. This is a widespread, shared view. Consequently, over 15 years now, healthcare has remained either the number one or number two issue volunteered as the most important problem facing the country today. So on one hand, there is a strong agitation for change and reform. The Canadian population knows that if we do nothing, we will move backwards. But because healthcare is so valued, indeed because it forms, I think as Graham mentioned earlier, part of our very national identity and sense of uniqueness, most Canadians resist any changes that might alter the system they so cherish. Basically, they want the system that we used to have. They cannot envision any kind of new system and new reform. This is why, over the last decade, any serious discussion around healthcare has amounted to nothing less than an intellectual jihad in this country. Andre Picard's piece in today's Globe and Mail makes a very, very good point. You mention the words two-tier, user pay, private clinic, sustainability, and you're a pariah. This is also why the healthcare portfolio has become a political tar baby to be avoided at all costs. 15 years ago, other than wanting to be the premier and the prime minister, you wanted to be the minister of health. Tony Clements thought that, and once he got in there, he wanted to run away so fast he couldn't believe it. Because there are all of these consensus and agitation for change, and no consensus around what kind of solutions we must put in place. So the challenge for healthcare reformers is not to follow public opinion, but to try to forge a consensus around new solutions where none exists today. So you might ask, where will that be found? Well, unfortunately, IT is barely even on the public's radar. When reminded, consumers will acknowledge that our paper-based operation is symbolic of how the system is not keeping up with the times. Yet only about 1% of the population cite IT as the most important problem facing the healthcare system today, and only about 1/2 claim to have even heard of electronic health records. Only 1/2 of the population believes a plan is in place for a pan-Canadian rollout of EHRs. Against this, virtually everyone supports the notion of such a plan. Similarly, the task of moving from a paper-based to digital records is universally recognized as a very good idea. There's a complete buy-in. While this might seem like good news, it's also actually part of the problem. Because EHRs are viewed, as we've heard in the focus groups again and again and again, as no-brainers. It was like, who would not do this? Patients feel no obligation to advocate on behalf of any kind of digital conversion. They just think that it's so commonsensical, there is no need for them to step up to the plate and make demands. There is no urgency because consumers find it inconceivable that it would not be done and wonder why it hasn't been done already. In fact, the only time you can get the consumer to be agitated around this issue, if you portent the prospect of it not happening, in which instance they go crazy. More importantly, patients have little understanding of how IT can improve care and health outcomes for them as individuals. Rather, they see EHRs as little more than digital paper. Basically, the ability to take this, scan it, put it in a computer, therefore eliminate the need for filing cabinets. As a consequence, they associate them with administrative efficiencies rather than anything that would affect them directly. Linking IT and EHRs directly to changes in patient care and health outcomes, and giving consumers a personal frame of reference that provides a more direct, personal, and emotional stake in IT is key to bringing them on side as advocates for the kind of transformational reform that the people in this room are seeking. It requires an ability to talk and think from an outside-in perspective, not simply an inside-out perspective. What do I mean by that? Let me try to illustrate by virtue of parable. Very, very successful physician. On the occasion of his retirement, colleagues got around, gave him a very, very valuable watch as a token of their esteem for him. This was his wont. Walked down the street, Bloor Street, checking his valuable watch. One day, to his chagrin, noticed that it was stopped. But at the same time, his great fortune, because right in front of him was this absolutely exquisite picture window with an antique grandfather clock backdropped by velvet, beautiful oak doors with brass handles. He opened them up. Waiting for them was a very distinguished gentleman in mourning tails and a pencil-lined mustache. And the physician explained that he had this very valuable watch and wondered if he could get fixed while he would wait it. Well, the proprietor explained they did no such thing. They didn't fix mechanical devices of any sort in his establishment. Well, now the physician was confused. He said, well, if you don't fix watches here, what do you do? The proprietor puffed himself to the full height and proudly said, why, sir, we spay the finest dogs and cats in all of Rosedale. Well, now he's really confused. He says, well, if you spay dogs and cats, why do you have that beautiful grandfather clock in your window? The proprietor said, buddy, if you were in my business, what would you be putting in the window? The point is, to get Canadians on side, it's not enough to just do your job. You've got to figure out what you're putting in the window. The challenge, therefore, is not to talk about why the system needs digital reform. Instead, what the patient gets with digital reform. Most dramatically, you have to link EHRs with saving lives. There's an emotional stake in the initiative. All our work shows that Canadians, when engaged, get it. They know that EHRs can reduce medical error. They understand that EHRs can reduce duplication in what they see as the discontinuity of patient care as they move through the system. While they have a very difficult time understanding the concept of secondary or health system use, they get very, very excited when you talk to them about the prospects of breakthrough and medical discovery as a consequence of mining the data for secondary use. And most importantly, a promise must be made for better patient care as a consequence. None of these things are easy. But let me tell you, my friends, when I was growing up, my father used to tell me, when it is easy, they let someone else do it, don't they? Thank you very much.